Bismillahirrahmanirrahim. Assalamu alaikum. Now another video station. So in the video I can see a 7 days old newborn ill-looking in hospital settings, looks not apparently well grown. However, I want to do the anthropometry, and he's lying in the supine position with orogastic tube in situ and IV cannula, and there is a cap on his head, and on the his lethargic hypotonic position, and the patient is hypotonic in posture, and there is abdomen is shows the abdomen is distended, periumbilical erythema is present, and I can't appreciate any visible visible vein, but the flank is full. So my in the X-ray there is bowel is distended and pneumocele intestinalis is present, and I can appreciate NG tube in the X-ray. And so my differential diagnosis: necrotizing enterocolitis, sepsis with ileus, bowel obstruction, volvulus malrotation, and spontaneous intestinal perforation, systemic candidiasis, food protein induced enterocolitis syndrome. And the history for onset, course and duration, feeding history, type of feeding, gestational age, urine output, any history of parental asphyxia, exchange transfusion, blood transfusion, and prostate and significant patent ductus arteriosus and formula feeding, and any antenatal steroid given or not, and the management, and in the examination, airway, breathing, circulation, vital sign, and respiratory system, cardiovascular system, para-abdomen examination, and reflexes, and any apparent congenital anomaly present or not. And investigation, radiological investigation, abdominal X-ray, and blood, full blood count, neutropenia, thrombocytopenia, peripheral blood film, there may be toxic granule, spherocyte present, CRP, urea electrolytes, capillary blood gas, evidence of metabolic acidosis, blood culture, coagulation profile. And then management, there is 3 stage of necrotizing enterocolitis according to modified Bell's criteria: suspected NEC, proven NEC, advanced NEC. In suspected NEC, there is systemic signs are temperature instability, apnea, bradycardia, lethargy, and abdomen is distended, and vomiting, blood in stool. But in the X-ray, there is normal or thickened bowel loop is present. In case of proven NEC, all the sign plus the radiological evidence of pneumocystic enterocolitis. Here the systemic sign, the above plus mild metabolic acidosis, thrombocytopenia, rest, CRP. Intestinal signs are all the above plus absent bowel sun, localized abdominal tenderness, and right quadrant mass. And radiological intestinal, significant intestinal dilatation, pneumatosis intestinalis, portal vein case, and ascites may present. In case of advanced NEC, there is all the things plus perforation, and systemic there is hypotension, bradycardia, apnea, severe respiratory and metabolic acidosis, DIC. Intestinal there is generalis peritonitis, marked tenderness, and distension of abdomen, radiological pneumoperitoneum. And then the management, always discuss with the management with consultant neonatologist. And initial management for all the cases, will keep the patient nothing per oral, and will transfer neonatal intensive care unit. And management of airway, breathing and circulation, if needed, intubate the patient and ventilate, and gastric decompression, and start antibiotic with flucloxacillin, gentamicin, metronidazole, and the total parenteral nutrition. Pain relief, consider morphine, diamorphine infusion. In case of proven neck, all the above plus we have to discuss with the surgical team. May need to transfer to the surgical center. Here, along with we will provide the if there is coagulopathy, fresh frozen plasma, thrombocytopenia or anemia, transfusion, thrombocytopenia guideline, and there may be hypertension, so hypertension guideline. Advanced neck, here we will refer to the surgical team. May need laparotomy or resection. This is the acute management, and subsequent management start consider feeding stage 1 after 48 hours, stage 2 after 7 days, and stage 3 discuss with surgeon and dietitian before restarting feeding. And late complication, there may be recurrence, stricture, short bowel syndrome, neurodevelopmental delay, and monitoring the child closely and review at least 12 hourly, and daily acid base balance, fluid balance, CBC and coagulation profile. Long term management, advise the parents regarding the sign of bowel obstruction, medical and surgical team follow up after discharge, and appropriate developmental follow up. Thank you.